Welcome, everyone, and thank you for attending today's HIMSS Industry Solutions webinar, Volume-Based to Value-Based Care at a Pioneer ACO. It is sponsored by Philips. Our speakers for today's event are Julie Reister, she's Chief Nursing Officer at Banner Telehealth, and Dr. Brian Rosenfeld, he's Vice President and Chief Medical Officer for Philips Enterprise Telehealth. Before we start the presentation, I have some housekeeping notes. Dr. Rosenfeld has no real or apparent conflicts of interest to report, and Julie Reister also has no real or apparent conflicts of interest to report. Our agenda for today is new models of care in a pay-for-value world. That part of the presentation will be presented by Brian Rosenfeld, MD, and value-based enterprise telehealth solutions applied at Banner Health will be presented by Julie Reister. The learning objectives for today are to learn about the strategies of other health systems regarding telehealth-based care to inform you of your own options, to identify some of the practical care delivery design considerations when implementing telehealth-based care models in the hospital and community setting, and to understand the clinical and financial outcomes that can be expected from telehealth-based clinical programs. This slide will give you an overview of how the benefits were realized for the value of enterprise telehealth in this setting. Treatment and clinical outcomes, reduction of mortality by 26%, length of stay by 20%, hospitalizations 45%, and ED visits by 67%. Cost reductions were achieved for total cost of care by 27%, inpatient costs per case of 16%, and with this also increased patient satisfaction to achieve patient engagement and population health goals. So with that, we'd like to begin the presentation, and I will turn it over to Dr. Brian Rosenfeld.
Thanks, Gus, and welcome everyone. Good afternoon, unless you're on the Pacific Coast. I'm going to try and take a more sort of population health view of the situation and try and set up Julie then to go into the Banner experience around utilizing telehealth for population management, as you will see from her presentation. It really is all fundamentally about a continuous care model. And what I mean by that is that telehealth gives you the opportunity to manage patients across the entire care continuum. And from a telehealth center, you can obviously manage patients in the emergency department, the ICU, the med-surg, skilled nursing facilities, in the home, and you're going to hear many of those aspects from Julie Reister about how they have done that at Banner. What's interesting, if you actually look at it, is that we spend much of our $3 trillion here in the U.S. on the powder blue 12%, which is called health care, or sick care in many respects, and that approximately 60% of all preventable deaths are rooted in modifiable behaviors and exposures that occur in the community. Now, as health systems, ACOs, begin to obviously take on greater risk, the need for addressing those aspects of care or wellness, I would call them, are going to become paramount. What you see here is that cost of care varies across I'll say the U.S. population, or certainly any geographic population location, with the top 5% of patients accounting for roughly 50% of all the health care costs. So what Julie's going to focus on, one of the aspects is the intensive ambulatory care program there at Banner, which is monomaniacally focused on that top 5% because that's where the money is. As you come down to 6 to 20%, you're looking at patients with, multiple chronic illnesses, but certainly not the 4, 5, 6 chronic illnesses and, 10, 15 medications. So, and much of the goal of the 6 to 20% is to keep them from becoming that top 5%. As you move down on the pyramid, you've got people with maybe one chronic illness, aging in place, so, the elderly population begins to sort of fit into this part of the pyramid, and then on the bottom is your wellness population. And while we have not historically, really focused on looking at populations, in this pyramidal format, I think it provides a very important way of trying to decide where you're going to focus your efforts if you're an ACO or an IDN. Now, healthcare productivity is also something that most, folks in healthcare don't really think about. But if you look at the pie chart on the left, what this depicts is that roughly 56 to, upwards of 60% of all costs in healthcare are related to personnel. So if we are not able to figure out how to do more with less, or at least the same with less, then we're going to have a very difficult time trying to manage costs moving forward. And on the right, you see an example of the EICU, which is part of the Banner Healthcare, iCare system that Julie is responsible for. And what that shows is that one intensive care physician with 2 to 3 critical care nurses can manage upwards of 130 to 150 ICU beds across any geography. Now, that's productivity, and that's what telehealth enables you to fundamentally do, whether you're in the ICU, you're on the med-surg floors, or you're dealing with large numbers of patients in the outpatient space. Pop Health is a puzzle, okay? And it fundamentally breaks down into these 9 puzzle pieces. I'm not going to go into any detail about any of them other than to say that this is how Philips approaches population health management, and we've got a rather extensive methodology for looking at each one of these puzzle pieces. So if you're an IDN or a budding ACO out there and know that you have to move in that direction, that we have obviously a methodology that could enable you to do that, we think, quite effectively. At the center there of the puzzle piece, you see telehealth, which we think is crucial for managing populations in the most cost-effective way. I'm going to focus primarily here on the right side because Julie's going to be addressing many of the other aspects, but from a telehealth center, you can manage patients across a large geography. You'll obviously see Banner, they cover patients up in Alaska and all over from their home base in Phoenix, and so you're not limited by geography. But the home represents a rather unique environment, and it's very easy when you have patients in the hospital to write an order, and invariably that will get done. Once patients leave the hospital, it becomes a contact sport. And so the healthcare team is really the outer concentric circle and has, while it has some influence, if you don't engage the patient and or their family, you will not get the kind of adherence that you need for managing patients in the ambulatory space. What this slide demonstrates, and it's recently, become somewhat in vogue because, and not to talk politics, but Bernie Sanders quick to point out that we spend all this money on healthcare and we don't get the kind of results we would need and want. The reality is that if you look at it, most of the OECD countries spend probably 4 times what we spend on social services, and that social services are really instrumental in healthcare and in managing those costs. So, it's very easy to point fingers at the U.S. and say you spend all this money, you don't get the kind of results. The reality is that we don't spend on the social services support, and what is sort of well appreciated is if residents in low-income neighborhoods could have the same kind of hospitalization and readmission rates as high-income neighborhoods, you would be able to avoid 500,000 hospital admissions per year. That's a big number, and really social services needs to take a much more prominent role in care of patients in the ambulatory space. The reality also is that one size doesn't fit all. And so if you go back to that pyramid, you could understand how you may need to spend more money on patients that are in the high-cost part of the pyramid, and you would need to spend less money on those moving down the pyramid because they're not costing you as much in the long run. This quote from Hippocrates from 2,500 years ago is interesting and obviously very germane to today's management of patients. So there's my summary slide. You can obviously take the time just to sort of read over the 4 bullet points, but at this point I will turn the presentation over to Julie Reister.
Thanks very much, Brian, and I want to just welcome everyone and thank you for joining us this afternoon for a somewhat abbreviated version of a talk that we'll be presenting at the upcoming conference in Las Vegas. So just a little bit of background in regards to Banner Health to provide some context to the services that I'll be talking about. Banner Health is one of the larger health systems in the U.S., and you can see from the slide what our geographical footprint is. Much like other large health systems, we have a variety of services that represent everything from large academic medical centers to small critical access facilities, outpatient clinics, specialty hospitals, etc. Banner is one of the original pioneer ACOs, and we were encouraged that in year 3 we were able to demonstrate more than $29 million in savings while we improved our quality score by 10%. And on any given day, I am confident that it takes the time, energy, expertise and intelligence of every single employee within Banner, every corner, I think, of this organization, to try to achieve these results and really try to understand and position ourselves for what the future looks like as we move from this volume-based care to the value-based care. So what I wanted to share with you was just few aspects of our telehealth journey and hopefully demonstrate to you how we think it's helped to contribute to positioning ourselves for this value-based care for the future. Our journey into telehealth actually started almost 10 years ago. Coincidentally to this date today, we are preparing to celebrate on Monday our 10-year anniversary of being a tele-ICU provider. We're very excited about that, and I want to share some of our outcomes that we've been able to recognize as we've cared for over 200,000 ICU patients in the last 10 years. But we didn't start with a big bang, without a doubt. Really back in 2006, we had just some questions that we were considering, really focusing on could implementation of tele-ICU be a system-wide strategy, predominantly to reduce variation and increase reliability. We started very small with just a couple of facilities because, as you can imagine, if we try to think back 10 years to 2006 and how different the world was, while we were very excited and optimistic about the clinical outcomes that we hope to achieve, you can imagine that the notion that we could dramatically reduce hospital days was a little bit concerning to some folks within our organization. But what we clearly realized early on was that our ability to save lives, to reduce complications, and to position ourselves to be in a situation where we could reduce hospitalizations was really time and money well spent back then. And as a result, over the course of these 10 years, the tele-ICU service is now a standard within Banner. So all of our ICUs, all of our licensed ICU beds are covered by this service. We have a dedicated team of intensivists, ICU nurses, an entire leadership team, and all the pieces and parts that would go with that support this service. By 2010, when we started to see these improved outcomes in length of stay and mortality, inquisitive minds really wanted to know, could we expand outside the ICU? Would it be possible to take our learnings from this centralized model and apply it outside the ICU in a general ward? What we did very early on was just use the technology that we had, and to date we have 3 hospitals where every room has two-way audio video and every patient is monitored, all their data is interfaced, and we've continued to really just study if we could identify adverse trends and intervene before bad things happen, and start to frame how we will look at potentially new models of care that even more fully integrate this virtual model in the future. Certainly it's people, process, and technology. A lot of us talk about that, and while you know, the processes are in place and the people that are in this remote team are so important, I think it would be important to point out that none of these outcomes that I will be sharing would be possible if we didn't have some very sophisticated technology. The digital analytics that are really behind delivering that information to our teams are really pretty spectacular. You can see just a brief display on this particular slide, not only of some of the surveillance alerts and monitors that this remote team has available to them. The population health view that you can see towards the upper right corner, where each one of those circles represents a single patient. And then certainly the ability to connect by a two-way audio video so that we're really working alongside the care team that's at the bedside. This is just an example of one of the very sophisticated tools that we've been able to incorporate as of last year that I kind of liken to the notion of a hot spotter. Many of you, I'm sure, are familiar with this notion, and some really interesting articles that were out there in terms of being able to take large data and look at pockets or hot spots of need or activity. I liken this automated Acuity function to that. It really, as you could see, would allow someone who has this data presented to them to pretty quickly see within which system there might be a concern or deterioration and a relative level of concern that we need to pay attention to that. So a very large red circle as compared to a small yellow circle certainly draws our eyes there, and when you're managing large populations of patients, you need to readily be able to identify when someone is deteriorating, and then what you'll see on this slide is dive right down into the patient level data that someone would need to be able to get the richness of what's going on. Anything from lab values to vital signs to demographic information. So here's our results in the intensive care setting, and I have just received the package with our final 2015 data and haven't had a chance yet to get that uploaded, but this data is from 2014, and this has been consistent and improving over the last 10 years. So for patients who had a portion of their ICU stay in a Banner Health facility, these were our outcomes. In 1 year, we were able to save over 46,000 ICU days, over 45,000 hospital days, with a very conservative financial team putting together length of stay cost avoidance that calculated out to upwards of $109 million. But what we believe and know is most important is that this partnership with the technology, people, process, all of our clinical standardization, and working with the bedside team, 1,890 grandfathers, mothers, sons were able to survive that were not predicted to do so based on our Apache scoring data that we use. So fast forward to about 3 years ago, as we continued to move into this value-based world, we partnered with our colleagues at Philips to really say, could we take our competencies that we've developed with the tele-ICU and tele-acute programs that I've just described and really put together a model that takes all of those pieces and focuses on the population that Brian talked about earlier, that top 5%. It was unique, I think, in a couple of ways from my perspective, in that our intent was not to put together a program that would be in place for 30, 60, or 90 days for these individuals. Based on our analysis of this population and doing some market research, we really came to believe that putting together a program that would be perpetual, so to speak, or would be something that would serve as a resource to them for their lifetime was the right way to go. It's pretty obvious when you start to look at the types of conditions that these patients had that we weren't setting out to cure them. We weren't going to cure them. These were individuals that have multiple chronic conditions, and we wanted to be able to support them in the comfort of their home in any way that we could do that. So we put together a dedicated team, not intensive care physicians, but again, match the types of providers with the resources that these patients would need. And we set forward to try to put the pieces and parts together to see if we could improve the lives of the patients in their home. So it was not nearly as easy as maybe we thought, or maybe we were a little bit naive and optimistic when we went into this. But this is where we tried to identify this population that we would serve. First and foremost, these individuals were part of our health network. So in regards to that, these were individuals that we were either partially or fully at risk for their care. We developed a flag in our electronic health record to identify individuals that had 2 or more chronic conditions from a discrete list that we put together, and also a utilization factor, which you can see on the slide. But as we started to present that group of individuals to the folks that would be the providers of care from the telehealth center, they just didn't quite seem to be sick enough, I guess. They weren't the types of patients that we thought really would benefit from this high-touch, high-tech program that we were going to put together. So there were a variety of iterations that really evolved and continue to evolve even today. But currently, our criteria, in addition to being a Banner Health Network member, is that these individuals have 5 or more chronic conditions and a utilization factor. What I find interesting is while that is the criteria for eligibility, of the 600 plus individuals that we're caring for right now, they're averaging 8 chronic conditions, and Brian's comment about 15 medications, it's closer to almost 20 right now. So it's a very, very complex population that we're trying to serve. The age range for those in the program currently is from 48 to 102, and the average age is 79. So certainly that's something that we were a little anxious about as we started to introduce the tools and the technology into their homes. From the monitoring devices you'll see on this slide, they look pretty traditional, tools that have been used for many, many years in the home. These are out in the individual's homes right now and are providing data back into the software that we developed, but we're certainly excited to see as wearables and all of the other options that are out there for monitoring continue to grow and continue to be available. We'll certainly look to see if we can find other options that even make it easier for the members that we're serving. In addition to those devices, we provide tablets, and much like I talked about with looking at the actual devices that will be in the home, we'll certainly be moving, I'm sure, towards a world where it will be more of a bring your own device. But in this particular program, as we were developing it and all the complexities that were involved with it, we made a decision to actually give them a tablet. What you can see is one example of what the screen can look like, and there's really 2 primary functions of this device in the home. One is the suite of activities that are in their well book, and this ranges from the ability for them to answer surveys, including surveys about how they're feeling. And that in particular has been very valuable because that information is trended and delivered to our remote team so that we certainly can identify individuals who may have been feeling relatively well but are indicating not by their physiologic measures but just in terms of their psychological being that they're not feeling so well today. The other component that we have been really excited about utilizing and our members have really enjoyed and benefited from is the video visit, and we'll be able to show that a little bit later on in my presentation. So here's the model of care that we developed. It's Banner iCare is what we've branded it within Banner Health, and what you'll be able to see, of course, is the most important part of our model is the member and the caregiver at the center. Up in the left corner, you'll see that these members still have their own primary care physician. They still have a clinic, an office that they go to for what some might call more traditional health care. But on the far right, you'll see the entire team that we've assembled that sits in our remote operations center caring for these 600 plus members. The physicians are gerontologists or internal medicine by background. We have several social workers that are trained in cognitive behavioral therapy. We've got a team of RNs. Interestingly, with Brian's pyramid, he showed it in the EICU. At this point, we're managing over 600 members with 3 RNs. We have a very busy pharmacist and then certainly a business office that has to assist us with all of the logistics that are required for a program like this. But I also want to touch on the health coach that you'll see down in the lower left corner. Well, these individuals may need traditional home health nursing care such as wound care or IV therapy, and we certainly partner with our home health colleagues here within Banner to do that. The only member of our Banner iCare team that goes out into the home, boots on the ground, is the health coach. It's not exclusively in person because they've also leveraged that video tablet, but we really have been excited to hear back from our members about the value that they think these health coaches bring to them. It may very well even be the secret sauce, so to speak. They're trained in motivational interviewing, and they really are a link back to not only our telehealth team, but to the primary care provider. Many of our members are not on a single electronic health record in the ambulatory setting. I don't know if that day will ever come. I'm hoping so. But until it does, as you can imagine, having someone that can fill us in if a member is planning to see a cardiologist or a specialist that we might not necessarily be aware of is incredibly important. So here's the role of the team, and this isn't really much different in a lot of ways than what you would see in some of our other telehealth programs, such as the Tele-ICU. Our job is really to respond to requests for assistance from the member. So rather than asking them to call into maybe their physician office when their primary care physician might be very busy with a full clinic that day in hopes that they'll get a call back at lunch or after office hours, we ask them to call our remote telehealth team to see what we can do to help them. This could be anything from troubleshooting their equipment to questions about medication, where we can link them with the pharmacist, to any other resources that really they might need. The ability to get their vital signs information, how they're feeling each day into the software and trend that does allow us to really monitor for those adverse trends and try to intervene to improve their outcomes. It also gives us a platform to implement whatever the best practices are for an ambulatory or primary care setting. And then, of course, continue to learn the richness of the data, what we can make modifications to the software, and really to better understand what their needs are. I will tell you that one of the big misses I think that we had on our side when we first put this team together was we did not at the very beginning understand the need for behavioral health in the way that we should have. Upwards to 80% of these individuals screen positive for depression, and so we've been fortunate in that we have a tele-behavioral health service here at Banner that is growing rapidly, and we have threaded those services in as another resource to our telehealth team that's taking care of these individuals. So much like with the software in the EICU, we needed to have patient-specific information that we could dive into if an alert came through on one of our 600 members, as well as the ability to get some alerting and trending. You'll see just here a quick screenshot of that dive down into patient-level information, which gives us a variety of elements that are very important if an alert comes across or a member calls in. Everything from whether they've screened positive on depression, who their medical power of attorney is, what kind of monitoring devices do we have in the home, and what are their current and active problem lists. On this screen, much like that orb that I described in the ICU, while certainly the complexity of all the devices in the ICU don't exist in the home, it will look, or it to me felt familiar to see this type of display in the right corner where you can see in this particular patient there was something in regards to their lab tests that was bringing it to our attention so that we could dive down deeper to see what was going on with that. So whether it's adherence, they didn't take their vital signs, or their vital signs are abnormal, whether it's the emotion icon letting us know that someone who had been feeling pretty good for a number of days is now starting to feel a little sad or depressed. It's really helped us to deliver the services on a more customized way for these individuals. So there are more lessons learned than I could probably cover in an entire day, but I tried to summarize some of them here, and this won't come to any a surprise to many of you who have started with small pilot projects, started to recognize some good outcomes, and then tried to scale it. Going from 2 years ago to a very small, very deliberate onboarding of 50, 60, 70 members to taking care of over 600 and now trying to scale it much, much greater doesn't come without a lot of new processes. So anything from rapidly getting equipment deployed within a short amount of time when we enroll someone to continuing to look for opportunities to interface that information to make sure that the devices are working well in the homes. But I think one of the equal, if not larger, challenges has been figuring out, are we making a difference? Are we making a difference in all the ways that we would hope, not only quality of life, but financial outcomes, and really nailing down those definitions and dealing with the complexities of claims data and comparison groups has been a real challenge. That top 5% and all of the information related to them has not been nearly as easy as one would have hoped. This is just a cover of an article that came out last week, and certainly if you'd like an opportunity to learn more about this program, please, you can certainly read this article or join us, certainly in a few weeks. But we were really excited at this time to at least feel like we had finally gotten some of that data and felt like the journey that we've been on for 2 years is starting to point us in the right direction from the perspective of outcomes. So for patients in which we were able to get 1 year of claims data prior to them joining our program, and they were in our program for at least 6 months, these are the outcomes that we've been able to demonstrate. We're really excited that even with all of the staff, even with providing all of this equipment, we've been able to demonstrate a 27% absolute reduction in cost savings and really some substantial reductions in hospitalizations. We continue to grow the population that we're studying as we have patients that stay in the program longer, as we have more patients where we have claims data back for 1 year prior to the program. What we're seeing is consistently these types of cost savings and even some deeper reductions in hospitalizations. One of the interesting things I think we found, and we predicted this, but it has come to fruition, is that the pharmacy costs for this population are going up a bit. And we would expect that. These individuals, we think now, are getting the resources that they need and the advice they need to be able to fill their medications and take them in a way that we really would like them to. I think the other thing that I would just point out is that for patients that do get hospitalized, and we certainly know that there's no way to avoid that altogether, the amount of time that they're in the hospital has gone down. So we think that that's also a good thing and leads to some confidence in handing them back off to the team who's caring for them back in the home. So I want to end my presentation right now with just giving you an opportunity to see a short video. I think what you'll find is that Mr. and Mrs. McCurdy can share the story of how this has made a difference in their lives in the home and describe it much more beautifully than I could ever do.
I'm comfortable. Are you comfortable?
Yes, I'm comfortable, sweetie.
Okay. I like Sun City. It's a nice community. Our grandchildren come over here once a week. We have a couple of good friends that we like very much.
correct one. In our age group, these are the things that are important.
When we first met, he was just a friend, nothing serious. He took me to a football game and gave me my first kiss.
Don't go overboard now.
Without communication, Ralph and I could have never survived the 64 years.
We know that the top 5% of patients in any system use a lot of resources, time, money, people, you name it. Philips and Banner are partnering to take care of the sickest of the ambulatory patients. We hope that we will be able to provide the support that they need to allow them to continue to live out their days at home.
Ralph's not very good at taking his own blood pressure, so I take his blood pressure every morning. But he gets on the scale, weighs himself.
184.4 pounds.
And then he goes to his little video. I'll learn to say tablet one of these days. At first, we were a little hesitant about all of this equipment, but as it was explained to us by people from Banner iCare and from Philips, we reached a point where we felt comfortable with it. Today, I would be lost without it. I'm just happy to be home with Ralph, to be able to talk to a doctor on a video, and we don't have to wait 2 or 3 days for a doctor appointment. It's fabulous. If I have an emergency, all I do is push a button. There's somebody at Banner iCare there for me immediately. Dr. Parent called us today on our tablet.
How are you?
Oh, we're doing very well. He wanted to know how we felt, and he recommended a couple of things. I mean, this is the kind of care that Ralph and I have never had. I mean, it's amazing.
This is the future. It's really an amazing model of care that doesn't exist anywhere else yet. When I have a team of people augmented by a lot of Philips technology, I can catch things earlier, treat things earlier, and intervene in a way that allows me to accomplish what I set out to do as a geriatrician, and then ultimately to do some good in these patients' lives.
I'm just thankful that we joined Banner iCare and that we have Philips equipment here. We're married 64 years. I can't say we'll have 64 more years.
We're trying.
Yeah, we're trying.
Innovation and youth. Philips.
With that, I'd like to hand it back over to Gus to take any questions that our audience may have.
Thanks, Pat. So we do have a number of questions, and the first one, I hope I get this name correct, from Fatasola Atetozoi, is asking, did Banner Health utilize a centralized or a decentralized governance model?
I'm not sure I completely understand the question related to the governance.
Mm-hmm. Well, maybe you want to talk about how you did approach governance. Was it a central committee, or was it a, pushed down to the departmental level?
Sure. So I'll take a stab at it, and certainly if we need a follow-up question, they can get in touch with me later. So this was really a partnership with the leadership of the Banner Health Network. So they were the ones essentially that are funding this program. These are patients that certainly they are at risk for. So in regards to the development of this program with Philips, we had 8 work teams, if I remember right, and certainly The strategies that we put together in each of those work teams, whether it was the model for staffing, whether it was the type of equipment, whether it was the technology, while we were in that developmental phase, all of those decision points as we put the program together really were shared with and endorsed and ultimately approved by the leadership of the health network.
Mm-hmm. Okay. And another question from the same person. How are you connecting the telehealth strategy to broader care management programs or technology from the ACO or payers?
Well, our strategy really within Banner is that, and really one of the primary roles that I've had is that I'm integrated in many, many aspects of care management. While I'm in the innovation division per se, that is part of care management. And so whether it's looking at how we take care of patients in the acute care setting who have a sepsis alert fire, whether it's how we take care of patients who present to the emergency department with behavioral health, or in this particular case, patients that are in the homes. We've adopted a strategy where as we see those pain points, as we see lack of access to care, as we see challenges with aligning ourselves to the new reality, we look at it through the lens of technology and telehealth, always trying to understand if there's ways that we can improve those outcomes while reducing the cost. One of our new initiatives that we'll be focusing on this year has really been related to patients who are admitted to an observation status within our hospitals. We have length of stay targets that we try to meet, but yet we haven't really aligned our staffing model in terms of the boots on the ground to meet that. And so we think, again, having a telehealth team and leveraging those tools can really provide a great resource to that.
Mm-hmm. Very good. So Michael Erdahl is asking, what reimbursements are tied into telehealth for the providers?
Well, I guess I can take that. It really depends, I think, how you set up the model, and it depends what type of a service you're providing. In the last example that I gave with the in-home program, as well as the tele-ICU example that I talked about earlier, those providers are either contracted or employed with us, and essentially we pay for their expertise and their time. So they don't bill in the traditional sense of the word in terms of a pro fee when they're delivering those services, which is different than a number of other telemedicine services across the country where you might have a specialist who sees a patient in follow-up in a rural site. And in that case, they're able to bill really what their traditional professional fee would be while meeting the CMS requirements and attaching the appropriate modifier.
What techniques did you use to gain clinical buy-in for the inpatient and the ambulatory telehealth programs?
And Brian, you can hop in anytime you want. I'll take this one, but certainly you have a lot of experience across the country.
I think the question is specifically about Banner, but I'll generalize after you answer, Julie.
Okay. It takes a lot of time and it takes a lot of effort, without a doubt, for buy-in. As you can imagine, in the ICUs, as we've brought on new facilities, we've also developed a strategy, so to speak, in working with their teams prior to implementation to really debunk some of the myths about what this partnership is and what the partnership isn't. And I think as we've had those conversations and implemented the services, it's shifted maybe more quickly than some might think to a lot of these providers understanding the benefit, knowing that they can only be in one place at one time, and quite frankly, I don't think this is unusual as compared to a lot of hospitals in the country. In that ICU setting, there aren't intensivists in the hospital on the night shift in a lot of facilities. So knowing that they can hand off that care to an expert who will ensure that everything is done to take care of their patients during the night has really been pretty wonderful for engagement, and it's also been very nice as we've tried to recruit new physicians on. And I think in the ambulatory space, we've worked very hard with that also. Very different model, as you can imagine, to have a patient who continues to have a primary care physician, but then you have another team who may be modifying their medications, who may be ordering in-home lab tests because of some changes. So we have some very deliberate strategies to communicate that back to them, whether that's being an interface into their electronic record, whether it's a call, whether it's a fax. But again, the idea is to improve the outcomes of these patients. We know that's what they care about, and we think if we can help them to do that, ultimately we're going to win over even those that were a little bit concerned about the model.
Yeah, I would say in a more global sense, and the Banner experience, since they've been doing telehealth for a long time, has migrated over time, so that when the original idea for an EICU was started back in 1998, it was very difficult for physicians and nurses to sort of grasp how this would help them. But over time, we've just seen broader acceptance, and particularly as younger physicians who were in training programs that had EICU there and are getting out into practice, I mean, it's much more accepted. As you're probably all aware, telehealth is being reimbursed more generally by CMS and even some of the private payers. There is a reimbursement code for chronic care that, in theory, Banner could be utilizing. That represents, I think, roughly $42 per month. Now, that can add up if you've got 600 members. But so the acceptance for telehealth in general, I think, is now really pretty pervasive, and the American Telemedicine Association deserves credit for, promoting that. And I believe that the government understands, as do private payers, that really the best way of getting access, high quality, at the most cost-effective rate is through telehealth. And I've been doing this for a long time. I would challenge anyone to come up with an alternative model that can deliver the same kind of results across, these large numbers of patients.
Well, great. And that's, I'm afraid, all the time we have for questions.
Great.
And so I'd just like to thank Dr. Rosenfeld and Julie for the very informative presentation. Before we wrap up, I'd like to ask the audience to take part in the exit survey that will be popping up on your screen as you leave. Thanks, everyone, for coming today. And a reminder that you will be receiving an email in the coming days with a link to the replay of the webinar for you to view again or to share it with a colleague. Thanks for attending, and I hope everyone has a wonderful day.
Thank you, everyone.